Thank you for coming tonight. My name is Francisco Esteva. I'm the director of the breast cancer program. I'm a medical oncologist at NYU. Is that okay?
Yeah.
All right. So I specialize in breast cancer. So I'll be talking to you about breast cancer only, basically, which is what I do. If you have questions about other types of cancer, we might be able to answer, but this is my area of expertise. So at ASCO, is the American Society of Clinical Oncology. Last June, there was, as you know, it's a very large meeting. About 40,000 people from all over the world get together and present new research, and we had a lot of discussions. And so I want to give you a highlight of what happened there. So this is just an overview of all types of cancer globally. All over the world, there are 8.6 million cases diagnosed last year, and 4.2 million deaths, unfortunately. So that's a huge problem, as you can see by the different countries and continents, how it's distributed. And then when we talk about breast cancer specifically, last year in the US, about 200,000 patients were diagnosed. All over the world is more than 2 million, and 626,000 women, mostly some men, but mostly women, died of metastatic breast cancer. So that's our major focus of research. How can we improve survival in patients with metastatic disease? Now, as you can see by the different, it's kind of interesting to look at these global pictures. For example, in China, in Asia, 47.5% of all cancers happen there, and 54% of all deaths occur there, while in America we do a little bit better. But anyway, still a significant problem. This is the distribution, and as you can see, all pink is breast cancer. So that tells you breast cancer is the most common disease in all these countries evaluated, 185 countries on this report, and in most of them, shown in pink, breast cancer accounts for the most common type of malignancy. This is how we diagnose breast cancer, usually by screening mammography, ultrasounds, MRIs. We do this routinely in women older than 40 years of age, mostly 50 years of age. And there's controversy as to how often we should do that, whether it's every year or every 2 years. But we at the cancer center here, we still do it after 40 years of age, even though some recommendations are to do it after 50 or so. After 50, when women are 50 years old and more, the mammograms is when they're most effective, and they can reduce mortality by diagnosing patients early. We diagnosed about, in the US, 60,000 patients every year with DCIS, for example, which is ductal carcinoma in situ. That is not invasive cancer, is what we call stage 0. So half of those, when they recur as invasive disease. And so that's the point of this screening: mammographies, ultrasounds, MRIs. Now, breast cancer is not a single disease, and this is a theme that is now, we are seeing this in all types of cancers. In the past, we thought we treated breast cancer as one disease. You had surgery, chemotherapy, radiation therapy. Breast cancer for decades was also a little bit different in that we knew there were some tumors that were estrogen receptor positive, ER positive, or progesterone receptor positive. We've known that for a long time, 30, 40, 50 years ago. And then but still, we treat most patients the same, except for that, the hormone therapy for the patients with ER positive disease. About 30 years ago, the HER2 gene was discovered, and that classified breast cancer about 15 to 20% of patients in that category of being HER2 positive. And then if both hormone receptors, the estrogen receptor and progesterone receptor and HER2 are all negative, we call it triple negative breast cancer. Now, these are only three genes or three proteins we look at routinely in every breast cancer: ER, PR, and HER2. But in fact, each cancer cell can express more than 20,000 genes. So that tells you an idea of the complexity of these. We know there are some of them that are becoming important, like the PI3 kinase, that there are now treatments targeting these PI3 kinase mutations, and many others. HER3, you heard about the BRCA, BRCA1, BRCA2, and so on. But there are many more types. So even today, we are actually treating patients depending on the molecular subtype with different treatments, and that will continue to evolve in the next years and decades. For patients if the tumor is estrogen receptor positive, we generally use endocrine therapy or hormonal therapy, tamoxifen, AIs, Faslodex, this type of hormone therapies. With, as we will discuss, now we use them in combination with what we call CDK4/6 inhibitors like Ibrance, Kisqali, and abemaciclib. If the tumor is HER2 positive, we use anti-HER2 therapy. The first one was Herceptin or trastuzumab many years ago, and now we have many more of these type of treatments. And for triple negative breast cancer, until now we had all we could offer patients with advanced disease was chemotherapy. There was not really a targeted therapy. Now, for all of the subtypes, as we do with all types of cancer, we're exploring a number of immunotherapies, so-called immune checkpoint inhibitors, or PD-1, PD-L1 inhibitors, and there are many of them. And in breast cancer, I'll show you an update at the end of my talk. For triple negative breast cancer, we have now that has been approved by the FDA called atezolizumab that improves the results in women with metastatic triple negative breast cancer. We also done research with anti-HER2 therapy that we presented in San Antonio in December, for example, and also with endocrine therapy, but those have not been as successful. So again, this is not a single disease. We need to figure out which patients respond to which treatment. So I divided my talk in three parts to give you an update. Again, there's a lot of data and it's hard to summarize all of this, but I just focused on a little bit of highlights for the different types of breast cancer. So that will be the hormone receptor positive endocrine therapy related tumors, the HER2 positive, and the triple negative. So that's going to be my talk. So what's new in HER2 positive, hormone receptor positive breast cancer? The latest news in the last 2-3 years have been these CDK4/6 inhibitors. There are 3 of them now approved by the FDA. Palbociclib is Ibrance, ribociclib, Kisqali, and abemaciclib, which is the generic name for the third one. And at ASCO, the most important trial, so all of them have shown significant improvements in postmenopausal women after menopause, treated with hormone therapy, with or without these new therapies, and all of them, the 3 of them, showed improvements in progression-free survival. So patients live longer without progression if we give them palbociclib, ribociclib, or abemaciclib in combination with hormone therapy. So what was reported at ASCO was this study, Mona Lisa 7, which is the first study where this type of therapy was tested specifically in premenopausal patients, so younger patients, younger than 50, or premenopausal, so women who are continuing to menstruate. So these women with hormone receptor positive, HER2 negative advanced breast cancer with no prior endocrine therapy for metastatic disease, 672 patients were randomized to ribociclib with hormone therapy or placebo with hormone therapy. So the standard of care is hormone therapy, and that's where we can use a placebo. It's not that the patients with placebo don't get anything. They get the standard treatment. Some of them get the added new therapy, and some of them don't. And that was done randomly by computer, so there was no selection. And the primary endpoint was progression-free survival. A key secondary endpoint was overall survival, and then the many other secondary endpoints. And what we saw in this trial was a significant improvement in overall survival. Now, this is very rare in breast cancer or any type of solid tumors, because patients get a number of therapies, one after the other, and we keep prolonging survival. But seeing an improvement in overall survival is very important, and we don't always see that. So in this trial, as you can see, I don't know how, it's hard to interpret these graphs. I know it's easier for some people or others. I like graphs, but for those of you who, let me explain how to read one of these graphs. So on the y-axis here, you have overall survival, 100% of the patients on top, and then if patients die, then the curves start going down. In blue, dark blue, you have the ribociclib or Kisqali plus endocrine therapy, and in the green, the placebo plus endocrine therapy. And then in the x-axis in the bottom, you see months, meaning time, and we go all the way to 5 years or so, 42, 4 years, 3, 4 years, and so it's a significant number period of time for patients with metastatic disease again. So as you can see, in the first 24 months, which is 2 years, you look from here back, there was no difference. If we were to report this trial at that point, you would conclude there is no difference, right? You see that, the left side of the curve? But then after 2 years, the curves start to separate. And more patients on the placebo had recurrences and unfortunately died of this disease. So the treatment provided a 29% reduction in the risk of death with a significant p-value, which is the statistical concept. So this was to me the most important highlight of ASCO, because again is the first study we've done, and we participated in this trial at the Pearl Marrow Cancer Center as well. It was a global study. Like, we've done several of these, which are again global. They are being done all over the world, but it's the first one in premenopausal patients with this new therapy showing overall survival. So that's something we're going to use in our patients immediately the day after ASCO, right? So it's an important clinical trial. Also, because one of the reasons we use endocrine therapy, first of all, if you have metastatic breast cancer and the tumor is hormone receptor positive, HER2 negative, hormone therapy is the most effective therapy. It's more effective than chemotherapy. And for many years, many doctors in the community and over, based on market studies, you can see many physicians were still using chemotherapy when we know it's not the most effective therapy. So it's not only the most, hormone therapy is most effective, but it's more tolerable. So you don't lose your hair, you have a better quality of life, and you could be on these treatments for as the first line therapy, or the first treatment patients get when they have metastatic disease, for up to 2 years, 3 years. I have patients more longer than that without chemotherapy. And in this study, you can see in these graphs, they separate very clearly from the beginning. And basically what it shows is that we can delay the time to start chemotherapy. Because when we give hormone therapy, sometimes for 1, 2, 3 years, and then we can switch to another hormone therapy. Some patients take our hormone therapy for a long time. At some point, the tumor doesn't respond to hormone therapy. We have to switch to chemotherapy. But if we can delay that, that's a benefit to the patient. It's not just something. Sometimes we always argue what's beneficial. We like to see changes on X-rays and scans, but what's most beneficial to patients is the quality of life and the longer they live, right? So we have to keep that in mind as well. This is another study in young women with similar disease, also premenopausal. We have a lot of data in postmenopausal, so that was this year. There was more information about the younger women. And this was a study done in South Korea where they randomized patients to this type of approach, palbociclib, and hormone therapy. Exemestane and leuprolide are hormone therapy we use in premenopausal women. And then palbociclib is Ibrance. Again, the previous study was with ribociclib. This one is with palbociclib. They are kind of the same family of medications. And they randomize patients to this type of hormone therapy with the palbociclib, which is the most effective therapy we have today, compared to chemotherapy. Because again, in young women, doctors tend to be, we want to use chemotherapy. We want to get a quick response. We want all these myths that are not really real, but in this study they actually compared this type of approach directly to chemotherapy. A small study, 184 patients, but as you can see in this graph, the outcome was better for patients treated with hormone therapy and Ibrance compared to chemotherapy. And I'm not going to show you in all these slides. I'm not going to go into detail about all the side effects and things like that, because there's a lot of discussion around those issues at ASCO. But in general, this type of hormone therapy, you can believe me, is more tolerable than chemotherapy, and that was shown in this trial. Moving on to another study in the hormone therapy population. This was a study from the UK, where this is now postmenopausal. So it's very important, as you hear me, when we see a patient with breast cancer, we always have to think about, first we think about what kind of cancer you have, right? Is it ER positive or not, and so on. But we also look at the person, and is this premenopausal or postmenopausal? The treatments are different. So for the clinical trials, it's the same thing. So in this study I'm going to show you was done in postmenopausal women, generally older than 50 or older, basically after menopause, and they were patients were randomized to fulvestrant, which is Faslodex, a hormone therapy, with or without a new treatment called capivasertib. This is not FDA approved. This is experimental treatment, but it's what's called an AKT inhibitor. For those of you who've heard about PI3 kinase inhibitors in the same family, it blocks a molecular signaling pathway in the cancer cells. And actually, in this trial, they saw that adding this medication to fulvestrant improved or delayed the progression of the disease, and also improved overall survival. Again, it's a small study. The one I showed you at the beginning was a large FDA registration trial. These are pilot small trials, so it's different. So we need to keep that in mind as we discuss this type of results, but this is promising. This is not an FDA registration trial, but it looks promising. What I found a little bit confusing in a way is that when they looked at the activation of the pathway that they were targeting with this medication, which is the AKT PI3 kinase pathway, in this particular trial, they saw benefit in both patients who had this mutation or patients who didn't. In other studies that have been reported recently with a PI3 kinase inhibitor, the benefit was exclusively for the patients who had this mutation. So this is just an interesting result. We need to follow up on this, but it was presented at the meeting there. Any questions about hormone therapy? Because I'm going to move to the HER2 positive type. Yes, two trials that looked at tamoxifen for 5 years versus tamoxifen for 10 years. And there are two studies that have been reported and published. The one is called ATOM, and the other one, I'm blocking the name. But anyway, two large, ATTOM, and the other one, I can look it up for you. They're both published in good journals. And they showed a slight benefit for the group of patients who took tamoxifen for 10 years versus 5 years. There's another study called M817 from Canada that look at tamoxifen for 5 years, and then an AI, an astrazole, for another 5 years versus placebo, and there was a benefit for the AI. So in general, for postmenopausal women, there seems to be a benefit for longer treatment compared to shorter treatments. But there is a small benefit, and the question is, can we identify those patients who may need longer therapy versus shorter therapy? Right. So we try to individualize and discuss with the patient based on the risk factors and the potential benefit. So if the patient has osteoporosis or bone density is going down, I would not recommend an AI. So the question is, you should continue tamoxifen or not. If the patient started when she was younger, the risk of endometrial cancer is very rare. For example, in the prevention trial where tamoxifen was given for 5 years versus placebo in healthy women, that's the best safety data we have. In healthy women in the prevention trial number 1 that was done many years ago by the NIH, we randomized about 11,000 healthy women to tamoxifen or nothing, and tamoxifen decreased the risk, the incidence of breast cancer. What we found is that women who were less than 50, there was no difference in endometrial cancer between the tamoxifen and placebo. There were some cases in both groups. And the same thing for blood clots and stuff. There was more hot flashes and other things which are real. But this study tells us what's real and what's not, because it was double blind. The patients didn't know, the doctor didn't know what they were taking. For patients who are older than 50, especially 60, 70, there's a slightly higher incidence of endometrial cancer, as you mentioned, so we have to take that into account. But it's also the not so serious side effects, but if a patient is having a difficult time with hormone therapy, with hot flashes, vaginal changes, or aches and pains, and you have to think about what's the benefit, So the benefit is relatively small. I always discuss with the patients and make a decision together about this. But in general, if the starting risk is low, like that patient with negative nodes, a score is low and so on, I would not continue for 10 years. On the other hand, if somebody had 5 positive lymph nodes or a high recurrence score or things like that, then I would continue if I can. So it depends. But at ASCO, there was actually a very interesting presentation. In one of these trials, I don't remember if it was the ATOM or the other one from the UK, they actually collected tissue from these patients, and they tested a new diagnostic assay called the BCI, the Breast Cancer Index. And in that randomized trial, only the patients who had a high score in that test actually got any benefit from the longer duration versus not. And patients with lower intermediate risk or scores on the BCI test, the breast cancer index test, they had no benefit for the additional 5 years. Now you can take that as validation. I'm sure the company that makes the test will say that. It's very hard to validate these assays because you need 10 years of treatment and 10 years of follow-up and so on. So they're very limited things. But I thought it was an interesting presentation, and I'd like to see more of that. We have Oncotype, we have Prosigna, we have this BCI, and some of these tests seem to predict a little bit. With Oncotype, with the score you mentioned, the 21 genes, is the one that I think we have less amount of data for. There's not a lot of correlations with more than 5 years of tamoxifen. But with Prosigna, for example, the PAN50, which is something we are using a lot at NYU, if you start with a low score on the PAN50, so-called luminal A type of breast cancer, those patients continue to do well even after 5 years of tamoxifen, very low recurrences. So again, we try to individualize whether it's by clinical criteria or hopefully some of these molecular diagnostics, but not of them have been validated, and we can argue about that. But I would personally feel comfortable if the tumor is luminal A. The PAN50 is based on 50 genes. Oncotype is 21 genes. All of them have different genes. But the PAN50, if it's luminal A, which is low risk usually, those patients rarely relapse after 5 years. So why do give them 10 years, So.
Thank you very much.
Sure, thank you. So the next, you tell me if I go over, okay? Because I talked slowly. So the second part is going to be the HER2 positive breast cancer. So this is a cartoon trying to show what HER2 represents. HER2 is a protein that sits on the cell surface. If you can picture a cell like a sphere, and on the cell surface there are receptors that make the cell grow or when they are activated. And HER2 is one of those receptors, but there are 500 of them. This is just one of them, but happens to be very important in breast cancer when it's amplified. And it belongs to a family of what's called tyrosine kinase receptors, type 1, and includes the EGF receptor, epidermal growth factor receptor, which is the HER1, HER2, 3, and 4. And HER2 is the one in blue that we are interested. As the receptors on the cell surface get activated in these cancer cells, and when a cancer cell is HER2 positive, it may have 3 million of these receptors, okay? A normal cell may have 10, 20,000. So it's not an abnormal gene, it's a normal gene. We all need it when we are embryos to develop the heart and other things. And when you're an adult, those growth genes get shut down by the system. Cancer hijacks those genes to work for them. So, and that makes the cell grow, invade, proliferate. It's a survival factor. The cell wants to survive and uses this type of mechanisms, dormant genes that are not needed normally, but are very powerful. For example, if you knock down this gene in an embryo, the heart in a mice, we don't do that in humans, the mice doesn't develop and the mouse doesn't, is lethal basically. So these are so how important, and that's why they are not usually expressed in normal cells, just to very little. But when they're amplified by these cancer cells, luckily we can find them. We have antibodies that our pathologists can find and say, hey, this tumor is HER2 positive, has a lot of this protein, and we target them with therapies. The first one was Herceptin or trastuzumab, which is a monoclonal antibody targeting that receptor, and that was developed in the 1990s at Genentech, was approved in 1998 for metastatic disease, and in 2006 was approved for the adjuvant therapy in patients with early stage breast cancer. Now we have many more that I don't have a slide about, but I'll tell you briefly to put in context a new development. So we have trastuzumab or Herceptin, we have pertuzumab or Perjeta is the commercial name, trastuzumab DM1 is called Kadcyla, lapatinib or Ticor, neratinib, we have lots of them now, and they work in different ways. And what was presented at ASCO this year was a new one in this family called margetuximab. It doesn't have a name yet because it's not FDA approved, but I'll try to explain how it works. These are preclinical studies in cell lines and mouse models, but what it does is basically it's an improved trastuzumab. It's like an improved genetically engineered Herceptin, if you will. So trastuzumab or Herceptin is a monoclonal antibody. Monoclonal antibodies are so-called immunoglobulins, are proteins that our body makes to fight infections usually. And Herceptin was using one of these antibodies developed and engineered to target cancer cells that target the HER2 receptor. But what they showed at ASCO was the results of a clinical trial where this therapy called margetuximab was given to patients with HER2 positive metastatic breast cancer in combination with chemotherapy, or they received the generic trastuzumab with chemotherapy. And basically, this I'll get back to this in a minute. But basically, when you look at these graphs, in blue you have the margetuximab, in red the trastuzumab, and there was a small improvement in the progression-free survival, meaning the amount of the time that patients take to develop progressive disease. So that's a positive result. It is modest, but I think it's encouraging because these patients were previously treated, and they still had some additional benefit from this therapy. And I hope they will move this into earlier lines of therapy first line and adjuvant and so on. But at least there showed some promising results in this clinical trial with this new therapy, margetuximab. There was another update, another trial using lapatinib and capecitabine. That's a combination of an HER2 therapy, lapatinib, and chemotherapy, compared to another one that is very similar, neratinib and capecitabine. And basically, the study showed an improvement in the response to the neratinib and capecitabine at the cost of more toxicity, especially as you can see here, grade 3 diarrhea was increased from 12.5 to 24.4. Grade 3 is serious diarrhea. I mean, even grade 2 is uncomfortable. We grade these toxicities as 0, 1, 2, 3, 4, and grade 3 is serious. So that's a problem with this. So a little bit better efficacy, I can't argue with that, but we are still, it's not my favorite, most favorite drug. I like to use therapies that are effective but also safe, especially in the palliative setting when we're interested in quality of life as well. So that's all I'm going to tell you about HER2 positive margetuximab, neratinib, and I mentioned all the 20 other trials. There are many things going on, but these were the highlights of the ASCO. Yeah. Generally, if we use hormone therapy, we use it in combination with HER2 therapy, or we use HER2 therapy alone with chemotherapy if needed, and then in sequence you may be using different types of therapies over time. So I can't comment on your case specifically, but generally, no, it's okay. Generally, we tend to combine hormone therapy with HER2 therapy. That's not unusual. So most of the times when we use HER2 therapy, we use it with chemotherapy, and then we use hormone therapy at some point, but not. So each case is different. So it looks like you're doing well. So we generally continue what works and gives us a good quality of life. So any questions about HER2 therapy in general? Again, I can't comment on a specific cases. And lastly, I'm going to show you what was presented in triple negative breast cancer. Again, that's when the tumor lacks estrogen receptor, progesterone receptor, and HER2. And there we have a couple of new things. One is immunotherapy, which I'll show you at the end, an update on the study we did here at NYU and all over the world as well. And then the new update was on this trial, which was a study done in Germany, but the German breast group, a very active group in clinical research, where they randomized patients with homologous recombination deficiency, HER2 negative tumors, to chemotherapy or chemotherapy plus olaparib, which is a PARP inhibitor. So I just said a lot of things, so let me explain a little bit. So homologous recombination deficiency is similar, or supposed to be, as having a BRCA mutation, like a BRCA1, BRCA2 BRCA mutations. When you have that, these PARP inhibitors tend to work in those patients. And again, the science is a little bit complicated, but as cells die, they repair themselves. And when BRCA, BRCA1 and 2 is one of the mechanisms the cell, normal cells and cancer cells use to repair their own DNA. And when BRCA is missing, they use a different pathway, what's called PARP. So if you have the BRCA is missing through the mutation and the PARP is blocked with the drug, that's basically the cell theoretically can't survive and it dies, what we call synthetic lethality, and that's how many of these drugs were discovered by developing these models in the laboratory, where we block one pathway, test 20 things, and we found one that kills them, and then that's how we find drugs like that. So olaparib is one of the PARP inhibitors. It's approved by the FDA for the treatment of patients with ovarian cancer and breast cancer with BRCA mutations. The homologous recombinant deficiency is a similar phenotype, as we call, but they don't have to have the BRCA mutation. There are many genes in the cell but it's the end result is very similar. And there is a test that can identify that as opposed to the BRCA. And the hope was that those patients would do better with the olaparib, PARP inhibitor, in combination with Taxol chemotherapy compared to Taxol and carboplatin, which is 2 chemotherapies. Now, and then after that they got additional epirubicin cyclophosphamide therapy, so a lot of treatment. But this was done in patients with locally advanced breast cancer before surgery. So sometimes we give these chemotherapies, carbo, Taxol, AC. In this case in Germany they use epirubicin cyclophosphamide, which is EC as opposed to AC, but very similar idea. Taxol followed by AC is what we use at NYU. In this case they use Taxol, carbo followed by EC, very similar. And the experimental group was the olaparib. And the idea was that in these patients with this deficiency in DNA repair, that the olaparib group would do much better than the other group. That was the hypothesis. And very complex study, but at the end of the day, basically, to summarize, there wasn't a significant difference. Now, one of the groups, the control group, as you can see, that received chemotherapy without the PARP inhibitor had received Taxol and carboplatin, and platinums also can interfere with DNA repair. So that was, the control was very good, if you will. So it's very hard to beat, to improve on that. So the pathologic complete response was around 50% in both groups, a little bit better with the PARP inhibitor, but not huge difference. So in this trial, they used Taxol in combination with the PARP inhibitor or Taxol with carbo, and these patients had never received any chemotherapy. These are newly diagnosed with what we call locally advanced breast cancer, stage 2 or 3 usually, and then they get chemotherapy before surgery, but they never had chemotherapy before. It's like the first diagnosis, and so their immune system is normal, everything is very clean, and then you go to surgery and you see how many patients had a complete response, meaning there's no tumor anywhere in the breast or the lymph nodes. And as you can see, I mean, the results are what we expect based on our current treatments, which is about 50% of patients do not have any cancer left. Those patients generally do very well. The other 50% is the ones we need additional therapies. But this is a concept we've developed years ago. We've been improving on this for more than 30 years. Before I moved to NYU, I was at MD Anderson in Houston, where we did many of these trials for many, many years. And so now it's well established that you can do this safely. And the question is, can we improve on that? So this pathologic complete response is a very good endpoint for these clinical trials, because patients who achieve that, most of them are cured. And then the ones who don't is where we need to decide what to do next. And we are doing clinical trials in that situation. So that's the model. And this is one of the therapies that was tested at ASCO this year. In the hormone receptor positive tumors, there was a significant improvement by using the olaparib, which is in pink, compared to the green. In the hormone receptor negative, which is where we would expect to see the biggest effect, actually there was no difference. So this is still very preliminary, very small sample size, and it's not something, as you can see on the left side, this difference is based on 19 patients to 10 patients. So this is not something we would base any treatment decisions. It's just an idea as to where to go next in clinical research. And then they look at patients who actually had the BRCA mutations versus not, and there wasn't a significant difference either. But the point is that most patients in this trial did very well. More than 50% of them achieved pathologic complete response, which is quite good. And then the other aspect in triple negative, so PARP inhibitor is one of the new therapies. The other one is immunotherapy, PD-L1 therapy, so-called immune checkpoint inhibitors. If you're not familiar with this, I'll try to explain in general. There are many of them now approved for many types of cancer: pembrolizumab, atezolizumab, darvolumab. There are many of them. This one is a study we did all over the world, but we played an important role at NYU. This was published in the New England Journal of Medicine, and this is the phase 3 trial. So in clinical research, you have phase 1, phase 2, phase 3. Phase 1, we look at safety, tolerability. Phase 2, we know the dose to use, and we look at the efficacy in a small number of patients. And phase 3, we expanded to a large number of patients. In this case was more than 300, a large number of patients. So we actually, for this combination of nab-paclitaxel and atezolizumab, we did the phase 1 trial in different places, but NYU was the main place for this. Dr. Adams is the first author in a paper that was published in JAMA, the Journal of the American Medical Association. And then this is the phase 3 study that was reported a few months ago, and showing a significant improvement in progression-free survival when you give this immunotherapy with Taxol compared to Taxol alone. And there was an update at ASCO on this clinical trial. So for patients who had this PD-L1 positive tumors is when the treatment was most effective. So PD-L1 and PD-1 are proteins like HER2, but are proteins that are actually expressed by the tumors, made by the tumors to make them invisible to the immune system. So the immune system cannot see the cancer cell because they use these magical things to make them invisible. So with these therapies, we block that, and then the cell becomes visible to the immune system, and the immune system can attack the cancer cell. So that's the idea. And it works in some types of cancer like melanoma. We've seen significant improvements in patients with metastatic melanoma with nivolumab, ipilimumab, pembrolizumab, atezolizumab, and many others. It's been, again, there are 50 different indications right now for this type of therapies, so they work. Not on every patient, but and in breast cancer, we've done studies in ER-positive, HER2-positive. They don't work as well so far, but in triple-negative, we've seen improvements in survival when the tumor is PD-L1 positive. So if the tumor is PD-L1 negative, they don't work as well either. But it's another therapy we can offer our patients today. So this was the update at ASCO from this trial that we did the phase 1 here, the phase 3 also all over the world, but Dr. Adams was also the second author on that paper in the New England Journal, so we played a major role in this trial. And this is just statistics, basically, summarizing what I told you, that in patients with triple-negative metastatic disease, now these were patients who had not received any prior therapies. So first line of therapy, patients who had multiple lines of therapy, we don't know. But if this is your first line of therapy and the tumor is triple-negative, then and we tested for PD-L1 and it's positive, then we would use the Taxol or Abraxane, which is a type of Taxol. Napa is called Abraxane, with the atezolizumab PD-L1 therapy. And then there was an update on pembrolizumab, is a another one of these PD-L1 blockers that helps the immune system find those cancer cells. And this is an interesting report based on a program organized by the American Society of Clinical Oncology, by ASCO themselves. They set up this clinical trial called TAPOR, which is basically a real-world evidence type of trial. A lot of patients are registered there, and we follow them and see how they do. And they looked at this pembrolizumab, which is another PD-L1 antibody therapy, to see if the patients what we call high tumor mutation burden respond better to this type of therapy, because the FDA approved this therapy, pembrolizumab, for any cancer that has this what's called MSI positive or tumor mutation burden. This type of cancers, if they have a lot of mutations in them, they tend to respond to this therapy. And in breast cancer, that's rare. It's less than 5% that they have those characteristics. But if they do, they seem to respond to to this treatment as well. So this is the last thing I have, I believe, but the important concept on this as well is that patients with metastatic disease now, we take a biopsy and we sequence the tumor to see what mutations the tumor have, and then we can direct the type of therapy we think is most effective for that particular type of cancer. But also, if there is a lot of these mutations in the tumor, something called MSI is positive, we can also use this pembrolizumab PD-L1 therapy. So that's all I have for you in terms of highlights. I hope this was useful and not too complicated. Thank you.